Then other therapies, for example, patients may have comorbidity, they may be taking antihypertensives. So those who are taking ACE inhibitors or ARBs, as of now, they can continue the same pending further evidence. There is no guideline recommending that they should not be given or they should be stopped. Also, a large number of patients may be receiving immunomodulatory agents. Immunocompromised patients are at increased risk for severe disease. So they may be on steroids, they may be on other biological agents. So that is for the disease, pre-existing disease that they have. In this situation, the decision whether to continue the treatment already going on or not to continue, because in this setting of infection, that again a blanket statement has not been given, and that decision has to be taken on a case-to-case basis. More often than not, it is advised to continue the standard therapy unless it is absolutely essential. Hence, the general recommendations for home management. So if most of the patients are fit to be kept at home, then certain guidelines have to be followed, and these are ideally the person should stay in a single room with an individual washroom. The patient movement in the house should be limited. Household members ideally should stay in separate rooms or at least stay more than 1 meter away. One should try and limit the number of caregivers. Preferably only one healthy person should be there with looking after the patient. Ideally, he should not be having any risk factors himself. Otherwise, he will himself be in a high risk category. Very good hand hygiene has to be followed, especially after any type of contact. Caregiver should always wear a medical mask whenever in the same room as the patient, and also by the patient when they are handling any kind of secretions, they wear the medical mask, and that should be disposed of properly as well. So there are separate guidelines for disposal of medical mask, and that guidelines should be, again, to reiterate some of them. One should avoid direct contact with respiratory secretions and body fluids. Laundry should be washed with a regular soap and water or with a machine wash at 60 to 90 degrees temperature. Infectious waste should be disposed of as per as the local sanitary authority guidelines. Whatever is prevalent or existing at that place where he is residing, there should be no reuse of gloves or masks. All frequently touched surfaces should be disinfected and cleaned regularly and frequently with 0.1% sodium hydrochloride solution. So this is commonly can be made at home, and this can be done very common. This should be done frequently to prevent any surface to body contamination. Ideally, there should be a dedicated linen and utensil for the patient, and one should use gloves and plastic apron for handling laundry and cleaning for the surfaces. So these are some of the practice guidelines or the practices which must be followed for a person who is being managed at home. Also, they should be given a clear-cut message, and they should be told what are the risk factors, what are the symptoms which can worsen. They should be instructed to return to the hospital if they develop worsening of any illness or any new symptoms come. What is the time for which home isolation should continue? It is ideally till one gets 2 negative PCR tests more than 24 weeks or 24 hours apart, or till 2 weeks after the symptoms have resolved if repeat testing is by chance unavailable. So based on these two guidelines, one can then continue the home isolation, and after that one can label the person as immune. The other important group which needs defining and care is the contacts, the close contacts. The definition of close contacts is any person who lives in the same household as a COVID positive patient, or a healthcare worker who has had a direct physical contact with a COVID-19 case or his her infective secretions when he was not wearing recommended personal protective equipment, or with a possible breach of the PPE, or any person who was living in the same closed environment or who was in a closed environment or had a face-to-face contact with a COVID case within a distance of 1 meter, especially or including air travel. So these are the definitions of a close contact of COVID positive patient. Management of these close contacts broadly are based upon quarantine measures, early case detection, and chemoprophylaxis. So we'll quickly go one by one. As far as quarantining of close contacts is concerned, they should stay in a well-ventilated single room with an attached separate toilet. And again, the same distance measures, the same social distancing measures apply. Keep 1 meter distance away from other members. Stay away from high-risk groups like elderly, the pregnant ladies, children, and persons with comorbidities. Movement in the house should be restricted, and under no circumstances they should try and go to any kind of crowded places or attend any other social or religious gathering. Again, hand hygiene measures are extremely important and they cannot be overemphasized, especially for these quarantined close contacts. Wash hands as often as possible thoroughly with soap and water or with an alcohol-based sanitizer. Surgical masks should be worn and they should be changed every 6 to 8 hours and they should be disposed of. One should try and avoid sharing household items, for example, the glasses, the dishes, utensils, the linen and bedding and other items. And the masks should be either disinfected using ordinary bleach solution or the sodium hypochlorite solution 1% prior to any reuse. So these are some measures that can be taken for quarantine measures. For early detection of these close contacts, one has to quickly pick up the symptoms. If symptoms appear, any of the symptoms, they should immediately inform the nearest health center by phone. The asymptomatic, direct, and the high-risk contacts of confirmed cases ideally should be tested once anytime between 5 to 14 days after coming in contact with the positive patients. So at this point of time, testing should be done, and these guidelines are by the ICMR, and we have to keep in kind of touch because guidelines keep on changing. So this is what has to be done. An important question comes regarding the role of hydroxychloroquine in this particular situation, and hydroxychloroquine has been tested in vitro and in vivo trials, and they have found faster viral elimination in the patients with COVID-19 infection. However, in clinical trials, there is no evidence for the clinical use by using hydroxychloroquine as a prophylactic measure so far. ICMR has very recently recommended the use of hydroxychloroquine in the following settings only, and they have emphasized only in these settings and not as a blanket for all. So healthcare workers who are directly involved in providing care to suspect or confirmed COVID-19 patient, they are eligible for hydroxychloroquine prophylaxis, and asymptomatic close contacts, household contacts of confirmed COVID patients, they are also recommended to take hydroxychloroquine as prophylaxis. And the dose in the first case would be 400 milligram tablet BD for first day, and then 400 milligram once a week for the next 7 weeks. Whereas in the latter situation, it is 400 milligram BD for first day and 400 milligram once a week for the next 3 weeks. So again, remember, these are the only two situations as of now where hydroxychloroquine prophylaxis is recommended. It is not recommended anything beyond that. It is not recommended for all healthcare workers across the board who may not even be coming in contact or who are not engaged in taking care of suspected respiratory or COVID positive patients. So this is an important message that one would like to give to everybody, because already this has led to shortage of hydroxychloroquine. So this kind of a panic situation should arise.